Not yet. It's still cool. We are technically live now, right? I will be quiet soon, so just tell me whenever you want me to change slide. Yeah.
No problems. Do we need to wait a bit longer, or are you happy for me to start?
It's your call. The only thing I will ask before we do anything is for the people who have come, can you see/hear us or hear? Yeah. Just type in the chat, please. And more importantly, can you see the slides? Just one person say yes or no. Cool. Right. So it's your call if you want to start.
Great. Hi everyone, my name is Aditi. I am a ACCS anaesthetic CT1 in North East London, and I'm basically going to be spending the next probably 30 to 40 minutes talking about post-op cardiac and respiratory complications. Although this is obviously an anaesthetic themed series of talks, this is particularly useful for anyone on kind of surgery placements, looking after post-op patients, A&E, even medical placements of people with procedures, so it is all very applicable to your ward work. I'm going to turn off my camera just to have internet. And I might do a few next slide, please. And also just a warning, if I go suddenly mute, it's because someone's walked in, but bear with me, hopefully it should be fine. So today we are aiming to firstly recognise common post-op cardiac and respiratory complications, to know the basic principles of how to investigate and manage these complications, and then actually talk a little bit about how we prevent these complications. Obviously can't cover every single post-op complication in the next 40 minutes, but I'm going to touch on some of the more common ones you'll probably come across, as well as some of the weirder and more wonderful ones, but obviously there is lots more that can happen. Next slide. So case one, and I would appreciate any chat interaction. I think this would hopefully make the whole process slightly more enjoyable and less painful for you guys. So we've got a 30-year-old female, one day post-op, lap appendix. She was noted on the ward round to be tachypneic, so struggling with her breathing, and hypoxic. SATs of 92 on air, respiratory 24, BP 110 over 65, heart rate 90, and temperature 37.5, so low-grade fever. And on examination, she has bi-basal inspiratory crackles. So can you guys just pop in the chat what you think your differentials might be? Any ideas? I don't know if I just can't see the replies or there is nothing in the chat, but it essentially looks like a young woman post-op who has some respiratory distress and is hypoxic. So very broad differentials. Got post-op sepsis, motor pneumonia possibility, ARDS, that's fair as well. That would all be part of my differentials. Other common things. So whenever I think of my differentials, I think of respiratory, because this is essentially a breathless and hypoxic person, and I kind of categorize my differentials where possible based on systems, because that helps me make sure I've covered my bases. I know lots of different people do surgical sieve, if you've heard of the vitamin ABC or vitamin CDE, whereas I quite like to do them in terms of systems. So one day post-op breathless hypoxic, think of all the respiratory causes, which is most likely what this is. So something like pneumonia, ARDS, PE, atelectasis that you guys are saying. I'd also be thinking of cardiac causes, something like acute pulmonary edema. Is she having ACS? It's unlikely given her age, which is worth thinking about these things. So talking about cardiac causes, respiratory causes, other generic causes like MSK, anxiety, things like that. It's all worth. Pain is all worth thinking about as kind of different systems. Yeah, those are all completely fair differentials. Next slide. So this is atelectasis, very typical presentation of atelectasis. And atelectasis is basically either small or large areas of collapse within the lung that normally happen post-operatively and can cause patients to be struggling with their breathing, be tachypneic, even be hypoxic. Classic features of atelectasis, so tachypnea, fast breathing, hypoxia, often quite like a low-grade fever, so I'm not quite hitting the 38s, but in the high 37s. A cough is quite common. And what probably distinguishes these ones is that they often happen within the 24-hour period post-op. Next slide. So risk factors for atelectasis. So the higher the ages, that's a risk factor. Being a smoker, so impacting respiratory function anyway. General anesthesia, so the actual process of being intubated and ventilated can increase the risk of atelectasis. The length of surgery, so longer length of surgery can. Any pre-existing lung or neuromuscular conditions, because of course that in itself is probably impairs respiratory function at a baseline, and then on top of that you're not ventilating very well, which is what leads to atelectasis. Prolonged immobility in bed rest and poorly controlled pain, particularly that of chest and abdo surgery, and for the simple fact that the chest and abdo injury are close enough, have incisions and operations close enough to the chest wall that when you do breathe, those areas hurt quite a lot, and that's why you restrict yourself from breathing as well. And actually, it's the lack of deep breaths is one of the biggest kind of pathophysiological causes of atelectasis, is not being able to take deep breaths, and so you lead to these collapses. Next slide. So these are pretty bog standard investigations, not necessarily for atelectasis, but for that undifferentiated respiratory patient. So, someone mentioned pneumonia and sepsis, very fair. You do blood cultures and bloods, a chest X-ray for anyone with respiratory presentations, an ABG because they're hypoxic, to tell what kind of oxygenation they've got. You take a sputum culture if you could, which in practice is obviously a lot harder to do them in theory, but if you're doing OSCEs and things, just say it. And the ECG, they're tachycardic and breathless, and that should be part of your workup as well. Next slide. So this is a chest X-ray showing an example of atelectasis in the right lower zone. Atelectasis can be quite extensive, can be bilateral, can be unilateral, and that little shadowing, I hope you can appreciate, that circled is a sign of collapse, and often you get raised hemidiaphragm on that side. You might get reduced breath sounds as well as crackles on examination. Next slide. So managing atelectasis, the key thing is around trying to improve ventilatory function post-op. So deep breathing exercises, just getting them to take slow, nice, deep breaths. And how you actually are able to do this by giving them adequate pain management. So a lot of these patients are on quite strong painkillers post-op. A lot of them might be on PCA, particularly people with chest wall surgery, or for example, like rib fractures and trauma, will have nerve blocks to that area to try and help with ventilation, because one of the big risks of chest surgery, or particularly rib fractures, and rib fractures themselves are usually not even surgically managed, but actually, as a side note, these kinds of either chest trauma or chest surgery can really, really limit breathing function. So often they need quite good going oral analgesia, and often blocks as well, to try and just let them breathe. And for rib fractures in particular, I've had a couple of patients with rib fractures quite recently that we've admitted solely for the purposes of pain management, who are young, otherwise fit, weren't for surgical management, because unless they're flail segments and things, you often leave them alone. But actually, we're just admitted for blocks and pain management, because the risk of it developing into atelectasis pneumonias are quite high if you're not breathing properly. Chest physio is quite good as a preventative as well as treatment modality for atelectasis. So again, what they do is use various different methods and breathing techniques to try and increase ventilatory function. And in really rare circumstances, you might need bronchoscopy, but it's extremely uncommon. And atelectasis, particularly in the early post-op period, is probably one of the most common causes of respiratory distress in a post-op patient. Moving on. So before we go into case 2, any questions on atelectasis, pop them in the chat now. Or if you think of any later, then we can do questions at the end as well. I'll just give you guys a few seconds. Okay, I'll probably just leave questions for the end, to be fair. So case 2, 60-year-old male, 3 days post-op for a laparotomy for ischemic bowel obstruction. Develops a weak cough, fever, shortness of breath at rest. The obs are below, as you can see, so hypoxic, tachypneic, tachycardic, and pyrexic. So kind of quite similar to the last case. And on examination, you have bilateral air entry and you've got crackles in the left base. Again, go for it with your differentials. we've got HAP, pneumothorax. Both very fair. And I probably put everything that people gave differentials for the last case are all applicable here as well. So ARDS, atelectasis, as we said, post-op pneumonia, they're all can be extended to this patient as well. Next slide. So yeah, this is in fact quite a common presentation of a HAP. Hospital-acquired pneumonia itself is defined by a pneumonia that develops at least 48 hours or more after a hospital stay and was not there on admission. In terms of features, again, probably already know this, but just to recap: cough, tachypnea, chest pain, delirium, particularly in the older population, secondary to infection, general malaise, fevers, and like I said, HAP normally 48 hours after, and that is part of the definition when they start coding for national statistics and things, that HAP is 48 hours after admission with a pneumonia that was not present on admission. Next slide. So risk factors, again, quite similar to atelectasis. So age, current smoker, respiratory disease, poor mobility, mechanical ventilation, immunosuppression, standard risk factor for any infections, and again, poorly controlled pain. And the reason they're so similar is essentially one of the risk factors of developing HAP, or rather, I should say, if atelectasis is not well managed, and you're getting these collapses and you're not able to have good ventilatory function, the actual lack of good ventilatory function post-op is one of the reasons people get pneumonias. They're not breathing very well in and out, so just, they're already not as mobile because they're in pain. Their pain's not well controlled, so they're not breathing very well, they're not moving very much, they're just not shifting air in and out, and that already predisposes them to then developing a HAP in an environment that is already pathogenogenic, so to speak. And so it all kind of comes together, which is why atelectasis and HAP have very similar risk factors. Next slide. So again, same investigations, underfrontiated respiratory patient. I'm not going to go over it again, but that's your kind of bundle of investigations that you would be starting off with. You probably would end up doing more down the line as your investigations become more, or your investigations become more nuanced, as your results become more nuanced. You'll probably go down some more routes, but that's a good place to start. Next slide. So chest X-ray, pretty bog standard, consolidation in the left middle zone, obscuring of the left heart border. You can still see some air bronchograms, which I was always taught, and to me means that unlike something like a pleural effusion where it's a block of white, you can see a little bit of air through and it all looks a bit hazy, and to me that's what I understand by that kind of consolidation air bronchogram kind of look. Next slide. So management of HAP, again, this is all probably very standard and pretty much management of any pneumonia or infection. So empirical antibiotics, and most trusts will have different guidances for HAP compared to CAP. Sepsis 6, so if you do think they're septic, and this patient probably is borderline, probably is septic, given their OBS, so you would treat them as if they have sepsis. Loads of people remember it different ways, 3 in, 3 out. I was taught Oberflu, that I thought was a good way of remembering the order. So oxygen, blood cultures, antibiotics, fluid, lactate, urine output. Adequate pain management again, and again, in very, very advanced cases, might you need to go to ITU for sepsis HAP. But hopefully, if caught early enough, most patients should be able to be managed on the ward and not need any further advanced respiratory support. Next slide. So in terms of prevention of atelectasis and pneumonia, and rather firstly atelectasis and progression onto pneumonia, so adequate pain control, we've talked over this, chest physio, and actually preventative chest physio for those that are high-risk surgeries or high-risk individuals can be quite useful, and then early mobilization where possible, again, just to get with the right analgesia to get their breathing regulated quicker. Next slide. So case 3, we have a 45-year-old female, 5 days post-op, lap cholecystectomy, complicated by an intra-abdominal collection. Overnight, she was noted to develop breathlessness and hypoxia, so similar theme across the board. So she's hypoxic, tachypneic, tachycardic, and has a low-grade fever. So again, very similar. I mean, feel free to pop differentials in again, but essentially, it sounds like you guys have been fairly good differentials across the last two cases, and this is no different. Again, probably respiratory. We're talking pneumonias, ARDS, atelectasis, PE exactly, HAP, all quite similar presentations. Yeah, we've got a few PEs. Next. So the one I'm going to talk about now is ARDS, but rightfully this literally could be a patient with pneumonia, it could be a patient with PE, it could be a patient with any of these, and that's why the kind of broad-based differential and broad-based investigations are really important. So ARDS is basically characterized as bilateral infiltrative disease of the lungs. It's essentially fluid filling in the alveoli, normally either after a primary lung insult or secondary to a wider systemic illness. Features of ARDS, so it's normally, or rather it should be within acute onset within 7 days, so it's not a chronic kind of worsening, but it should happen within 7 days of X insult or develop within 7 days. You're hypoxemic, so low PaO2. You will see bilateral infiltrates in the chest X-ray, and the alveolar edema itself it would not be explained by fluid overload. So it's not like someone's got heart failure and decompensated, or that they're a CKD patient who's decompensated and they've gone to fluid overload. It has to be in the absence of these causes. This is a kind of ARDS picture. Next. So the causes can be divided into direct and indirect causes, like I mentioned earlier. So common causes of direct, so lung-specific pathology ARDS, we've got pneumonia, and you can get ARDS secondary to that. Smoke inhalation, so people that have been in house fires, particularly those that have been in enclosed house fires, when they come in to A&E, you should have a low index of suspicion just for monitoring, and particularly if they've had a significant exposure. If you can see soot around the mouth, get them to blow their nose. If you can see soot, in the phlegm and in what they're blowing out of their nose, it's just worth thinking: do we need to observe these patients for a bit longer? And if they've got any kind of respiratory distress, with that you have a low threshold to investigate thoroughly. Aspiration again, so aspiration of food, aspiration of gastric contents in surgery. That particularly when you're doing an RSI, or when you're doing emergency surgery where they've not been starved, that can lead to aspiration, which can then lead to ARDS, as well as a fat embolus, which we'll come on to later. And then indirect causes are sepsis, so you can get ARDS secondary to systemic infection, sepsis. Acute pancreatitis can cause ARDS. Polytrauma patients, for those of you that may work in a major trauma centre and see patients that have come in with road traffic accidents, multiple injuries, they go into kind of complete systemic unwellness. Their clotting goes off, their inflammatory markers go off, they develop all kinds of weird complications that don't even seem related to the trauma in the first place. A major burn's again quite similar, where you just have a complete systemic upregulation of everything, and just to massively upset the circulation, and it just all the fluid ends up in the wrong place, and that can cause ARDS. Next slide. Again, bog standard investigations, I won't labour the point, but here's your set. Next. So this is quite a typical X-ray of ARDS, or they both are rather, and the one on the left of the screen looks worse in terms of it's absolutely everywhere. It might be the penetration, it might be the angle, but essentially what you do get is bilateral infiltrates that can look quite striking, and it can be quite similar to like really severe pulmonary edema on chest X-ray. For those of you that worked during COVID over the last couple of years, it can look quite similar to really bad COVID pneumonia as well. And I think when COVID pneumonia was initially being understood, there was a lot of overlap with, is this like an ARDS picture? Do we treat it like an ARDS? Which there's a lot of academic work around that. But actually they look very similar on chest X-rays, and it's this bilateral infiltrative type picture. Next. So management. So ARDS it's not got a great prognosis if it's full-blown ARDS, and unfortunately there isn't a huge amount that you can do for it. The mainstay is essentially supportive treatment, so supporting their ventilation. They will often need intubation and ventilation for a few days at least to try and until they've cleared a lot of their They're inflammatory and infiltrative processes. Treating the underlying causes, of course, is actually treating the infection, the sepsis, whatever else is driving the burns, whatever else is driving the ARDS. Really severe cases may need ECMO, which is extracorporeal membrane oxygenation, which I won't go into. It's all very, very advanced critical care type systems, and I think there's only like 4 or 5 centres in the country that do it. And really, really, really severe COVID patients did also need this. So again, similar in terms of, probably is more similarities than we think in their pathophysiology. But people do respond to supportive treatment and do survive from it. But it does have a fairly higher mortality than your pneumonias, or atelectasis, or whatever, or your HAP, for example. I think already said. Yeah, so worse prognosis, supportive management, likely need ICU. Next. Any questions so far before we move on to the next few cases? Nope. Fab. So case 4, we've got a 45-year-old female, 5 days post-op, total abdominal hysterectomy, complaining of chest pain since this morning and breathlessness on exertion. So when she's been mobilizing with the physiotherapist, they notice she gets quite breathless and isn't normally like this. And despite her pain being under control, she's still quite breathless. Her chest is clear. She's slightly tachypneic. Her SAT's a bit borderline. She's tachycardic, normal blood pressure, and her temperature's okay. So what are our differentials here? So I can't have anything added to the chat, but essentially similar to the last few. Yeah, we've got PE. Again, if I think of it in terms of, in the summary, this is a 45-year-old woman who has got chest pain, tachycardia, and tachypnea. Again, is it respiratory cause? Is it a cardiac cause? The respiratory causes are all the ones we've talked about before. Cardiac causes, is she having ACS? Is she got a PE? Is that respiratory or cardiac? Both. She got a myocarditis, a pericarditis, an infection secondary to her operation affecting her heart. Again, other causes of chest pain is gastric causes of chest pain, psychological causes of chest pain. So using that systems-based differentials is quite helpful. But I agree, PE is quite up there with our differentials. Next. So this is in fact quite classic of a PE. So you'll normally get dyspnea, pleuritic chest pain, so chest pain that's worse on taking a deep breath in, worse on coughing, actually having tachypnea, both difficulty breathing and pain on breathing. Hemoptysis is quite rare, but it can happen, and actually tachycardia as well. I think for patients that I've seen on the wards of the PE, which when I first started F1 a few years ago, I was quite surprised actually how many PEs there were on the ward. And I don't know if it's whether I started during COVID, and actually that's obviously a prothrombotic state, but I think these patients are so mobile on the wards and are often quite unwell. And actually, in a patient that's just tachycardic for no reason, I've seen more often than not now, they often start to go down the whole PE investigation. If you can't explain why this person is tachy, it's worth keeping this in mind, because they can be quite insidious in how they present. And I've patients with PEs, like bilateral multiple PEs, who actually do not simply present them with fast AF or tachycardia. So it is worth, as much as chest pain is a presentation of PEs, I think having an unexplained tachycardia in someone who normally doesn't is also worth just keeping in the back of your mind. Next. So risk factors of PE, so recent surgery, prolonged immobility, so particularly over 3 days. So this patient was 5 days post-op, known thrombophilia, previous VTEs, again, age, smoking, the classics, getting old and smoking don't seem to be working in your favor for cardiorespiratory complications, which is probably why these patients are often higher risk for anesthetics as well. Pregnancy and postpartum, current and active malignancy, and then hormone replacement or combined oral contraceptive pill are all PE risk factors. Next. again, the standard chest investigations you would do for this patient. Moving on. This is a chest X-ray, which is normal. I was going to ask you guys to actually try and find what's going on there, but it's a pretty normal chest X-ray. And often patients with PEs, and more often than not, they'll just have normal chest X-rays. Obviously, you still do them as part of your respiratory panel, but they will often be normal. Sometimes you can get reactive pleural effusion, or you can get pulmonary edema if you're having like a concurrent cardiac event or something. Although it would end up being your P's will normally affect your right heart, and it would have to be like a full-on systemic right-left heart situation to be having acute pulmonary edema, but it's not impossible. But normally it will be completely fine. Next. So the classic well score, then we all get MD Calc out for, which is particularly helpful, I think, both on the wards, but I find it really helpful in A&E, and I'll come on to another score I find quite helpful in A&E that I've just remembered. But starting with a well score, so suspected PE, you do a well score, which I'm going to have to double check and look up on MD Calc because I don't remember what it consists of. Let's see if we can find it. Yeah, well score for PE. So it gives you 3 points for clinical signs and symptoms of DVT. If PE is the number one diagnosis or equally likely, that's another 3 points. Tachycardia, immobilization of 3 days or surgery in the last 4 weeks, previous diagnosis of VTE, hemoptysis, and malignancy within the last 6 months are all give you various points to try and characterize a well score. So well score under or equal to 4, but if you're still suspicious for PE, you would do a D-dimer. And if the D-dimer is negative and is one of those low suspicion for PEs, you can pretty safely say, I don't think this person's got PE, let's look up for other causes. But if the D-dimer does come back raised, do a CTPA. In your well score above 4, they don't even need a D-dimer, they just go for a CTPA. I feel like we always get asked, can someone have a PE and a negative D-dimer? Personally, I haven't seen it, but it's probably possible. I think if you're really, really, really suspicious of this is really, really sure to be a PE, more likely than not your well score, if you're that sure, would probably be above 4. But it's always, even if the D-dimer is negative, but if you really, really aren't too sure and think it still is, talk to a senior. They might want to scan anyway. I've personally not seen D-dimer negative PEs, but I'm sure they're out there. Who knows? But key thing is D-dimer is better at excluding a PE. It's generally considered a good exclusion criteria, but D-dimers can be positive for a ridiculous number of reasons, and often these post-op patients will be D-dimer positive, either secondary trauma or surgery, infection. So it's not very good. Like, it's a good exclusion, but it's not very good. Like, this is a PE for sure, if that makes sense. Next. So management of PE. So we start off with anticoagulation. Back in the day, then when I was at med school, and we were always taught low molecular weight heparin as your first choice. I know that there's now a shift to start DOACs a lot earlier. Some places will start it as a first dose as opposed to doing low molecular weight. Where I work, we still give subcut as a first dose. Look at your trust guidelines, but essentially the mainstay now are direct oral anticoagulants. A few people, for various reasons, may still be on vitamin K antagonists, so something like warfarin, which obviously requires a lot more monitoring, and it is very specific to the patient and what their pathologies are and what other concurrent diseases they have. So again, normally provoked PEs would get anticoagulation minimum 3 months, but often, and there used to be a 3 months for provoked, I think 6 months for unprovoked, but often we see these patients on anticoagulation for much longer. But essentially, when you're discharging them from hospital, they'd be referred to an anticoagulation clinic. So you'd start them, and then the anticoag clinic can follow them up in terms of how long they need to be staying on anticoagulation for. In terms of like patients that are really, really, really sick, the ones that are hemodynamically unstable, with right heart strain and a proven PE, you might consider thrombolizing them. This would only really be done in like a resus setting in A&E or with ICU critical care support on the wards. And there's a huge number of contraindications and cautions, like recent stroke, recent surgery, etc. So you do have to be very careful. And again, that's all very senior led, but it's good to know. The other thing is, if a patient with PE or likely PE does go into cardiac arrest, and thrombolysis becomes part of your management. And then prevention, obviously, we don't want these patients to have PEs in the first place, and thromboprophylaxis is extremely important. Often on the medical wards, this will be in the form of subcut low molecular weight heparin. In the perioperative patients, sometimes when they've got higher bleeding risks, we would go with TED stockings instead. But it's just worth always remembering, my trust has big pop-ups for VTE every 48 hours, and as annoying as they are to cancel, they're actually very, very important because PEs can be very bad. The other score I was going to tell you guys about was the PERC score, which I only discovered when I started working in A&E, which is quite a good kind of rule out score. Omar, you very helpfully put the MD Calc link, if you don't mind putting the PERC score one as well. It's PERC, and it's a good way in A&E to help rule out a PE. So the PERC score, if you guys have a look, is how it doesn't say, this person's got a PE, but if someone's got chest pain, sounds a bit pleuritic, but you're not sure, you think it's probably lower respiratory tract infection, pneumonia kind of thing. They're quite young, but you're just not too sure, like, do I do a D-dimer, do I not? But then you go down once you do a D-dimer, if you think it's already going to be positive for some other reason, PERC score is quite a helpful way of being like, this is a pretty good rule out. And essentially, the metrics are age over 50, heart rate over 100, SATs under 95, unilateral leg swelling, hemoptysis, recent trauma or surgery, prior PE, or hormone use. And if they score a yes on any of these, then you cannot rule out PE. But if all of these are a no, then you can say this is really unlikely to be PE, and you'd be happy. And my seniors in A&E are pretty happy to use the PERC rule as a way of saying, if we already don't think this is a PE and this helps us say this is probably not a PE, it's a good one to use. Next. So last case of the evening, we've got a 75-year-old male, 24-hour post-op IM nail for a subtrochanteric neck femur fracture. He was noted in the morning all around to be short of breath, confused, and developed a new petechial rash on his legs. SATs were slightly hypoxic, he's tachypneic, tachycardic, low-grade fever, and GCS14, so a bit confused. So what are our differentials here? Yeah, so we've got sepsis, which is a very fair suggestion. I think that has to be quite high up on the differential. Someone with a fever, tachycardic, they do present as sepsis. I think the petechial rash and confusion you've got to think about is this meningococcal sepsis. Fat embolism, exactly. Fat embolism is one of them that we'll talk about, and more. I think new petechial rash, you have to think about looking at the clotting and things like post-op DIC, and although not very common in someone with sepsis with multi-organ failure who's already really unwell, they can go into DIC and get petechial rashes. Next. The one with that is fat embolism syndrome. So fat embolism is essentially when fat globules manage to get their way into the circulation, which normally happens from surgery that has higher exposure to fat, so something like Longbone surgery. Yeah, PE also very good differential. And fat embolism is a syndrome that occurs when these patients become unwell. So not all patients with fat embolism actually get fat embolism syndrome, but the syndrome is normally characterized by tachypnea, tachycardia, hypoxia. Often they'll be quite confused. They may get a petechial rash, as well as a low-grade pyrexia. So it can be so non-specific and very similar to your PEs, ARDSs, etc. The petechial rash is one to keep in the back of your mind, and confusion of how they're often differentiated from a PE or other respiratory pathologies. Next. So that shouldn't say HAP, it should say fat embolism. So young age is actually, compared to the others, which are is all of the risk factors. Longbone fractures because they have increased exposure to fat. Closed fractures, I'm not sure why. I'm trying to think, maybe because the fat's all contained and so it's more likely to go into the circulation as opposed to go out. Don't really know. Multiple fractures, conservative management of longbone fractures, and if you are fixing, then iron nail compared to other procedures has a higher risk. Again, I'm not sure what the pathophysiology behind why specifically iron nail, but it is a risk factor. Next. So investigations, we've got blood, and the reason I say film is because actually sometimes you can see flat globules on the film. Again, your standard chest X-ray, ECG, and also I would do a CT head, which I'm going to add to this list as well. They've got a new confusion with petechial rash. Have they bled into their brain? We don't know. And just make sure with the blood you do a clotting for these patients as well. Next. So this is this is basically the same image as ARDS, because often the fat embolism, when it becomes a fat embolism syndrome, actually presents with ARDS, and that's what the complicating feature of the fat embolism is that causes them to become unwell. So again, bilateral infiltrates, lots of fluid in the alveoli. Next. So management of fat embolism syndrome is not any different really to ARDS. It's supportive treatment, probably needs ventilation, may need ECMO. So again, it's more, rather than treating the fat embolism, you're treating the syndrome that normally presents as ARDS. Next. And it's worth thinking in terms of how to prevent fat embolism syndrome. So for those fractures that need fixation, trying to fixate them as early as possible. And for those procedures that are a bit higher risk, like iron nail, you want to just have continuous monitoring of all the vitals, and that's also a big part of the perioperative and anaesthetic management of these patients. A point to note, so not all fat emboli lead to the syndrome, as I mentioned. Fat embolism syndrome is extremely rare. And most people I know have not seen it before. It's something we get taught at med school, and actually, even if you have tiny bits of fat that do come into the circulation, the chances of it going into full-blown fat embolism syndrome is quite rare. But when these patients do get it, they become really unwell. So it's worth just thinking about keeping in the wider differential. And I think for all of these patients, just early escalation to critical care is really important, because that's where they're going to get the best supportive management. Next. So that was our 5 cases for the evening. To summarize, I've gone through a range of different conditions. As I said, it's not spanning every single post-operative complication that can be. I didn't touch on COVID, although COVID is very much a reasonable post-op complication, and a form of HAP in its own sense, isn't it, in terms of they come in without it, they get it when they're in hospital. So that's one to keep in the back of your head. The actual process, the stress and physical insult of surgery themselves can decompensate a lot of pre-existing conditions. So people with CKD, with ischemic heart disease can get pushed over the edge into ACS and acute liver failure, kidney failure. So it's worth thinking about the acute complications of what their concurrent diseases are. But importantly, things are common. A patient with that presentation is way more likely to have atelectasis or a pneumonia than a fat embolism syndrome, but it's worth keeping the differentials quite broad. Whatever you do with these patients, and this has probably been drilled into you throughout medical school and work, but systemic ATE approach, very important, and actually just managing as you go along the way and stabilizing, and asking for help, and you won't go wrong. Keeping the differentials wide and systems-based, and just having a framework that helps you keep a wider base of differentials, which I found particularly helpful when I was presenting my OSCE. So if any of your medical students' OSCE is coming up, actually when you're talking through differentials, saying the respiratory causes of, cardiac causes of. But then equally important now that I'm working in A&E at the moment, where you see so many undifferentiated patients, and you can have an element of decision fatigue, and actually just thinking about reminding yourself about each system helps me make sure that I'm asking all the right questions, and helps me not forget one obvious system just because I've gone down X line of questioning. So I cannot stress enough how helpful it is to have a system for differentials and questioning your patients. I think with post-op, complications considering a post-op timeline. So, has it happened in the first 24 hours? Has it been 3 days? Has it been 5 days? Because that often is a telltale for what pathology is going on with these patients. And lastly, escalate, ask for help. You're not alone, even if it feels like that in the middle of the night. And ward cover, you are not alone. You can always ask for help. And I just have a low threshold to ask for help for an undifferentiated sick patient because you're better off asking for help and then not needing it when they arrive because you've actually managed to stabilize them well than being out of your depth in the middle of the night. So just ask for help and then you're happy, everyone's happy. That is it from me. You can go to the next slide. Any questions? Feel free to pop them in the chat, and if you think of anything otherwise, obviously email me, or if you have any general anesthetics related questions or anything like that, yeah, feel free to pop them in the chat as well.
So I'm going to show my face now. So if anyone has any questions, feel free to put them in the chat box. We will stay here for a couple of minutes. Obviously, if you need to go, Aditi, please just say so because I know it's late on your end.
No problems. We can give everyone a couple of minutes.
Yep, sure.
See if anyone's got any questions. Yeah, I hope this is helpful. I've just tried to do a quick whistle-stop tour and try and keep it just as general as possible because I appreciate that's probably what you're seeing on the wards as opposed to like the super nitty-gritty stuff.
Oh, there you go. You're getting good reviews.
Oh, I was meant to put a feedback link out, but I can maybe send that to you and Laura to send out if that's
the great
okay.
thing about Medal is it actually comes with a feedback survey already.
Oh,
so
fab,
I can
amazing.
send you all the data and you'll get a certificate as well from Mind The Bleep, which I'll
That's
send
very
you
helpful. I always
immediately.
forget to put. I've got a little QR code. And I always forget to put it up.
That's all right. I can send you the feedback that we get. It may not be the same questions.
That's.
You sure? All right.
Yeah.
Cool. All right. So please, those of you who are running away, please make sure you fill in the feedback form. It helps a lot for all of us, for the great portfolio game that we have to play, and also to improve our presenting.
Yeah, and this as well because I probably will do this presentation again. But if there's anything that you wish there was included, you thought this would be different on, then do let me know, and I'll keep evolving.
Sorry, guys, I just realized I left the feedback form in edit mode, so you may not be able to access it. So please do fill it in now, and also you get a certificate after you fill it in as well. Apologies about that. Sorry, my bad, guys. I've sent it to your emails, and this is the direct link. That was my fault. Apologize.
I think if there's not any immediate questions, I need to shoot off if that's okay.
Yeah, it's fine. All right, so I
Great,
will.
thank you very much for having me.
No problem. I'll just stay here for the technical stuff.
Cheers.
Bye bye. See you.
Bye bye.
All right. I just tested the feedback link. It is working. Sorry for the delay. Thank you for attending, guys. And for those of you who are still here and maybe listening to me, the final talk in the series is happening next week. It will be on enhanced recovery after surgery. There'll be a lot of how can I say? There'll be a lot of meta-analysis. How can I say, criteria that me and Ben will be going through, so we'll be presenting it. Hopefully it's interesting. We'll be hopefully debunking some myths you may see in your wards or hospitals, which may not actually be the best practice according to the latest data. So please come for that. You will all get invited soon. Otherwise, thank you for attending. Have a good evening, and please fill in the feedback. Thank you very much.